So the title of today's event is Advances in Bladder Cancer Research. Next, I would like to introduce our moderator for today's event. His name is Dr. David Berman, and he's a professor of pathology and molecular medicine and the director of Queen's Cancer Research Institute at Queen's University. His research focuses on the basic translational and clinical aspects of bladder and prostate cancer. He has authored over 60 scientific publications which have helped establish embryonic signaling pathways as important and useful drug targets in cancer. He has identified bladder cancer stem cells and has helped to shape surgical pathology practice. He has also held leadership positions in research, education, and administration. Dr. Berman received his MD and PhD degrees from the University of Texas Southwestern Medical School and residency in anatomical pathology and postdoctoral in molecular biology and genetics training at Johns Hopkins University. Please join me in welcoming Dr. David Berman to today's event.
I'm going to give an overview about what's happening in bladder cancer research and tie it into some of the talks you'll hear today. And all of these talks were supported by OICR funding. So I'll discuss what makes bladder cancer research special, how we're addressing its unique challenges. And I'm here today as a representative of the Queen's Bladder Cancer Group. Michael Ong will have to be an honorary member for today. That's QBCG, sort of pun intended, and I'll talk about how bladder cancer research is a bit of a Cinderella story, which is a term coined by Rob Siemens, the leader of our group. This is our group after receiving Terry Fox Research Institute New Frontiers grant, which we couldn't have done without OICR's help. And it investigates a lot of the things be talking about today, including what Madhuri Koti, our PI, will talk about. So a few facts and figures about bladder cancer. In Canada, 37 people are diagnosed a day with bladder cancer. It's the 5th most common cancer in Canada, with 80,000 Canadians living with bladder cancer. Most often presents as blood in the urine. It's the most expensive cancer to treat, and that's largely because of high recurrence rates. Smoking is the most common risk factor, and for all comers, there's a 77% survival rate, but that depends largely on stage. Stage is divided into two categories: non-muscle invasive bladder cancer, or NMIBC, consisting of carcinoma in situ, non-invasive papillary urothelial carcinoma, and superficially invasive papillary urothelial carcinoma that extends only into the connective tissue just below the bladder surface, which is here. And then the other category is muscle-invasive bladder cancer, which makes up only 25% of patients, but is responsible for all bladder cancer deaths. And here the cancer invades into the outer muscle wall, also called the muscularis propria or beyond. These two are managed. NMIBC versus MIBC are managed very differently. They have very different dynamics and demographics. NMIBC is managed by local resection and treatments given inside the bladder, whereas muscle-invasive bladder cancer is largely managed by removal of the entire bladder with or without systemic treatments like chemotherapy and immunotherapy. Because of their different dynamics and demographics, they are often studied quite differently. And as I'll discuss later, the mechanisms and situations by which NMIBC progresses to MIBC and the origins of MIBC are somewhat mysterious. Bladder cancer is a cancer of the elderly. There will be increasing numbers of elderly over the years and increasing cases of bladder cancer. For example, in men over the age of 80, bladder cancer is just as common as prostate cancer, which is known as the most common visceral cancer in men. Bladder cancer has the highest lifetime treatment costs of all cancers from diagnosis to death and the highest caregiver burden. Currently, medical costs are over $650,000 per year, and that doesn't include indirect costs to caregivers and family support. Bladder cancer is a bit of an orphan cancer, particularly in terms of research funding. In 2021, bladder cancer in Canada ranked 24th of 27 cancer types in terms of the amount of funding it received. And this is despite all the challenges and opportunities to work in bladder cancer research. In Ontario, bladder cancer is the only cancer type with decreasing year-over-year overall survival. This chart on the x-axis is different years, and the overall survival is on the y-axis. So we need to do a better job. Major opportunities for doing a better job include streamlining and fortifying our current approaches. So take things we know how to do and do them better. Versus innovating. So in terms of there should be a number 2, not a second number 1 there. But in terms of streamlining, I think the first talk on improving grading is a good example. And the second and third talks will discuss how to improve leveraging host immune responses using innovations in how we treat bladder cancer. Bladder cancer, there's a lot of opportunity for improving outcomes by just adhering better to guidelines and benchmarks. A recent paper by Dr. Siemens and colleagues showed that they looked at 7 different metrics of quality care for bladder cancer. In none of those metrics were adhered to more than 50% of the time, and most were adhered to less than 10% of the time. So there's a lot to improve in terms of care delivery. You'll hear a talk from my group about one of the first steps in deciding how to manage bladder cancer is to assign it a grade. This is something that pathologists do, and depending on whether you're low grade or high grade, that will often play a deciding factor on whether you get just infrequent surveillance or you get frequent surveillance followed by many, many doses of intravesical immunotherapy called BCG. So grading is very important, and you'll hear about how we're using digital tools to make that better. Just on the topic of BCG, it's the gold standard for immunotherapy and sort of the poster child as well. It's the first immunotherapy to be widely used clinically. It was developed here at Queen's by Alvaro Morales, shown here 50 years later, visiting Madhuri Koti's lab and hanging out with her PhD student at the time, Priyanka Yolmo. It's given as an instillation into the bladder, and it's an attenuated mycobacterial strain that causes a brisk immune response that can kill cancer cells and prevent recurrence and progression. Despite how good it is, and it's the best we have, 40%, it could be better. 40% of patients will recur or become unresponsive to BCG. Management of BCG recurrences is increasingly complex and expensive. And those patients who fail BCG, they have worse outcomes than patients who never got BCG in the first place, which is interesting, counterintuitive, and something that many people in the field are researching right now. So this is Canadian data from the Canadian Bladder Cancer Research Network that on a slide provided by Rob Siemens, and many of these other slides were also provided by him. And it shows primary on top, these patients do better, and secondary MIBC, muscle-invasive bladder cancer. So secondary are patients who've been followed and had NMIBC, non-muscle invasive, lower stage bladder cancer, and were under physician surveillance and treatment for probably for long periods of time prior to their diagnosis of muscle-invasive bladder cancer. They then had cystectomy, and they actually ended up dying faster than these patients with primary MIBC, where they presented with higher stage cancers. We have no idea how long they had gone undiagnosed, yet they did better. And one of the leading explanations for this worse outcome of patients who have a previous diagnosis is the possibility that BCG, at least in these patients, causes immune exhaustion, and the immune system can no longer help clean up cancer cells and kill them in these patients. So nevertheless, immune responses to bladder cancer are among the better responses across all different cancer types. And there are therefore many efforts to leverage this using more and different approaches to activate the immune response. These are the agents approved by the FDA in 2025 for bladder cancer, and almost all of them are immune checkpoint blockades, agents used in different combinations or at different timing than previously. The one exception is an antibody drug conjugate called enfortumab. A little bit earlier in the pipeline, but in clinical trials and under investigation now, are novel therapies for early stage BCG unresponsive non-muscle invasive bladder cancer. These include immune checkpoints and modulators, and those agents are boxed in red, FGFR inhibitors, antibody drug conjugates, and chemotherapy instilled directly into the bladder, either as a liquid or with a slow release device called the TAR-200. As an example, there's some positive signals from these kinds of studies where Sasanlimab, which is a PD-1 blocker, when added to BCG, caused superior event-free survival in NMIBC compared to BCG alone. And I think that gives you a background of this setting in which you can better understand the three wonderful talks we'll have today. So first, Evelyn Yach Taylor Zhang from my lab at Queens will start us off with quantitative grading to improve non-muscle invasive bladder cancer management. Evelyn is a computer scientist now pursuing her PhD in pathology, and she develops machine learning tools for medical images and prognostic classifiers. Taylor is a master's student also in my lab, and she works with Evelyn to improve how we grade bladder cancers, more on the pathology and clinical side. Next, Madhuri Koti will present development of a therapeutic approach to target aging-associated immune exhaustion in high-risk bladder cancer. She's my colleague at Queens, and her lab investigates how factors such as sex and age influence immune responses to bladder cancer and its treatments. She leads translational studies using both human and animal models that reveal mechanisms of immune dysfunction. And these mechanisms help explain differences in patient outcomes and also point towards new therapeutic strategies. Finally, Dr. Michael Ong from the Ottawa Hospital will present neoadjuvant immune-modulating radiation with Durvalumab prior to radical cystectomy in patients with muscle-invasive bladder carcinoma, which is a window of opportunity trial, and he'll explain what that means to you. He's a medical oncologist specializing in genitourinary cancers. He designs and leads national and international clinical trials that test new immunotherapy combinations, and his work bridges basic translational and clinical science, aiming to improve outcomes for those with muscle-invasive disease. So you're in for a treat. After these talks, there will be a question session with the panel, and it will follow the third presentation.
So today, Taylor and I will be talking about quantitative bladder grading to improve non-muscle invasive bladder cancer management. So just as a little refresher, non-muscle invasive bladder cancer, or NMIBC, is a form of bladder cancer characterized by the accumulation of malignant cells on the interior lining of the bladder wall without invading the muscle beneath. NMIBC includes bladder tumors with stage CIS, TA, and T1. While patients with NMIBC generally do have a better prognosis than those whose tumor has infiltrated the muscle, they often suffer from really high recurrence rates.
So histologic grading in NMIBC is a key prognostic tool based on the size, shape, proliferation, and organization of cancer cells. Higher grade tumors have more abnormal appearing cells, tend to be more aggressive, and have poorer prognosis or survival outcomes. Currently, there are two bladder cancer grading systems, the WHO 1973 and WHO 2004 systems. So as you can see, the WHO 1973 system stratifies grade into three categories: grades 1, 2, and 3, or G1, G2, and G3. The WHO 2004 system, on the other hand, differentiates bladder cancer grade into low grade and high grade, with an additional benign category called papillary urothelial neoplasm of low malignant potential, or just PUNLM for short. So low grade incorporates all of G1 and the low end of G2, while high grade incorporates the high end of G2 and all of G3. So this 2004 system was created to replace the 1973 one because the latter was criticized for its apparent lack of reproducibility, accuracy, and inter and intra-observer variability, given that grading is a qualitative process. An essential goal of the WHO 2004 system was to provide detailed histological criteria for each category to improve intra-observer reproducibility. However, there has been an ongoing debate over which grading system is more accurate and whether this 2004 system actually provides greater value than the 1973 one. Additionally, regardless of value, both systems still rely on subjective approaches that suffer from poor reproducibility and accuracy.
So digital pathology offers a unique opportunity to transform the diagnostic and prognostic landscape of modern pathology. Its role is a simple one. It's to acquire, store, and interpret pathological slides in a digital environment. One of the largest benefits of a digital adaptation is that it opens the doors for computational analysis. One of the most powerful and developing fields of computational analysis is artificial intelligence. This section of computer science broadly captures algorithms that enable computers and other machines to simulate human intelligence. Within the field, there are several subspecializations differentiated by how they approach the simulation of intelligence. An example is machine learning, which relies on creating models by training an algorithm on existing data to make predictions or decisions. This allows machines to make inferences based on data without explicit programming. The quality of these models is determined by their accuracy, sensitivity, and specificity on a test set of unseen data.
So what does a digital pathology workflow actually look like? So firstly, a bladder cancer tissue sample is obtained via a transurothelial resection of bladder tumor or a turbid. During this procedure, a urologist inserts a cystoscope into the bladder through the urethra to remove the tumor for examination. The tissue sample is sent to a lab and embedded in paraffin wax to create a solid block for sectioning. Then sample slices are obtained from the block using a microtome and are mounted onto glass, which are known as whole slides. Staining is usually done using HPS or H&E to allow the pathologist to examine the cellular and tissue structure. From here, representative samples can be scanned and digitized using a slide scanner, so this process is not destructive and digitally preserves slides and their staining without the threat of deterioration that the originals undergo. After the slides are on the computer, they can be explored in more depth using digital image analysis software like Visiopharm. This allows for the pathologist to view the samples much like they would under a microscope, with the additional benefit of running computational analysis as well.
One thing that there's no getting around, even in a digital format, is the size of whole slides. So on the screen to the left, we can see an example of a whole slide. Holding in your hand, it's only going to be a few centimeters large, but when we pop it under a microscope and start zooming in, we can see that it gets quite a bit bigger. We can see on the right side. Our project implements quantitative nuclear grading, which aims to standardize grading through the automated extraction and measurement of grade-based nuclear features. We address the size challenge of whole slides using the Visiopharm environment to develop a develop and run a series of applications that isolates concentrated cancer ROI and extracts QNG measurements. Our workflow begins by differentiating between the sample tissue and the rest of the slide. From there, we can remove any folds, blurs, bubbles, or cautery artifacts to ensure the data that we're extracting later is correct. Then any stroma or lymphocytes are excluded, so we're left with the ROI of concentrated cancer nuclei. Once this sequence is completed, we can efficiently run Visiopharm's nuclear segmentation application to map and measure nuclei, which allows us to extract quantitative nuclear measurements for each nucleus in the image. For a whole slide, this on average is about 500,000 nuclei and only requires about an hour to extract all of that data. Presently, there are 11 different nuclear features we can quantitatively measure, each aligning with the criteria that pathologists use in their assessments. Out of the 11 that Visiopharm exports, 9 describe nucleus morphology. Our 10th feature is based on mean variance hematoxylin, which is a measure of how dense the nucleus chromatin is based off of pixel intensity. We also calculate the tissue's mitotic index, which equates to the number of cells currently undergoing mitosis divided by the total number of nuclei. Much like grading, identifying mitotic figures is plagued with gray areas that make it difficult to confidently identify them on typical H&E and HPS stain slides. At a 20x scanning resolution, as we can see at the bottom of the slide, mitotic figures look more like a smudge than a cell dividing. For a pathologist, even if they were absolutely certain a nucleus was a mitotic figure, counting by hand ends up being a lengthy endeavor. Our group reliably detects these cells with an augmentation to the base Visiopharm application using a collection of heavily annotated and validated images. Now, I said 11 different nuclear features. You'll notice 2 more. And with all of the data that we extract from whole slides, we still have a somewhat incomplete picture of all of the nuclear features that go into grading. So we've developed 2 additional quantitative features, nuclear outliers and then nuclear orientation.
Yeah, so why do we make these features? As mentioned, there's currently a debate regarding the 2 bladder cancer grading systems. So although the WHO 2004 system has more detailed histological criteria to try and improve reproducibility, it fails to identify the most aggressive cancers by excluding the G3 category from the WHO 1973 system. To address this issue, previous studies have recently proposed forming a 3-tier hybrid system to improve risk stratification by including the G3 category. However, the system still relies on qualitative characteristics, causing subjective grading and unvalidated category boundaries. Thus, using Visiopharm, we were able to create a new feature to identify these abnormally large nuclei to help validate the splitting of high grade into G2 high grade and G3. So as you can see on the left, this is an example of a G3 tissue sample. As you can see, there are a few abnormally large nuclei, which we believe are a potential indicator of G3 tumors. So how do we add a new feature to identify these nuclei? So as you can see, the nuclei in the G3 samples are rare and extreme, and as such, statistical measurements like mean and standard deviation would be insufficient to capture the atypia, given their sensitivity to central tendencies rather than the extremes within the data. Thus, we use the interquartile range to define outliers as any data point outside the defined upper and lower bounds relative to the IQR. The detector was trained using a reference cohort of 5 low-grade and 5 G2 high-grade samples to define our high-grade and G3 thresholds respectively. The detector was then applied to the remaining samples to compute each sample's percentage of nuclear outliers. Apart from this feature, we also obtain measurements of location and variation to see if other quantitative metrics can differentiate between the WHO 2004 and WHO 1973 grading boundaries. So using this outlier-based approach, we then examined whether these features could stratify patients by recurrence risk between low-grade and high-grade, as well as between G2 high-grade and G3. So as you can see on the left, patients with more abnormally large nuclear perimeters tend to have lower recurrence-free survival rates. However, as you can see on the right, larger diameter outliers could also significantly predict recurrence risks, except this time in just our G2 high-grade and G3 cohorts. So these findings support the subdivision of high-grade into G2 high-grade and G3, as certain samples characterized by larger diameter outliers have lower recurrence-free survival rates. Additionally, from our measurements of location and variation, we found that in the WHO 2004 Punlump and low-grade cohort, patients with higher mitotic counts and higher standard deviations in convexity, so that just means more variation in nuclear shape, also had poor recurrence-free survival rates. Thus, like in the high-grade cohort, treating all low-grade tumors the same therapeutically is problematic due to these differences in recurrence risk. So also from Visiopharm, we created another feature based on the previously mentioned orientation. So Punlump, as I said, is a category that was introduced in WHO 2004 grading. They're not necessarily malignant. However, there has been a debate regarding whether they constitute a distinct category or just a subset of G1. Ordered nuclear orientation is a key hallmark in lower grade cancers, and thus Visiopharm was used to quantify nuclear orientation and determine if this could provide evidence regarding whether Punlump should actually be differentiated from G1. So each of our scan slides was split into an 8x8 grid to improve computational efficiency and to account for local variations in nuclear orientation across different regions of the tissue. With the coordinates, a direction vector was created for each nucleus, calculating the angle of this vector from the horizontal. Next, a reference schematic in the shape of a comb was created to mark the ordered nuclei orientation. So as you can see, this comb consisted of a central line with 5 branches equally spaced, and each comb was imposed onto each tile in the 8x8 grid. Particle swarm optimization was used to determine the optimal rotation angle of the central axis, minimizing that difference between the comb and all individual nuclei in the sample. To actually quantify this difference of the distance between the orientation comb and the nuclei vectors, we use the cosine similarity formula, which yields a value ranging from 0 to 1, with higher values indicating greater similarity. So as such, more organized nuclear orientation will have a cosine similarity closer to 1, while disorganized nuclear orientation, represented by vectors with a perpendicular angle, will have a cosine similarity closer to 0. So although we're still running our orientation analysis, here's a visualization of one of our samples. So as you can see, the optimal rotation for one of the tiles here on the right is 36.8 degrees from the horizontal, and this tile is really aligned with a cosine similarity of 0.97. However, the optimal rotation for the entire sample on the left is 12 degrees from the horizontal, and the overall cosine similarity is 0.76. So we're working to optimize the number of grids, as again, each sample exhibits local variations in nuclear orientation across regions, and some samples also have fewer cells than others do. To do so, 3 students have graded a subset of 20 samples based on the orientation of their nuclei on a scale of 0 to 1, with 0 indicating complete disorganization and 1 indicating high organization. So we obtained the median value of these 3 scores, and this will be served as the reference value. Next, different tile sizes will be run based on an average number of nuclei per tile. So these values will be compared to the reference value that we get from the 3 students. And based on this, the optimal average number of nuclei per tile will be used to determine grid sizes for the remaining samples. Histograms and survival analysis will be ran afterwards to see if our results improve.
Now, all these techniques are all well and good, but they don't really matter if the people that need them, like pathologists and patients, can't use them. For that, we'd like to propose a few use cases where this data really shines. An interesting place to start is visualizing features in a spatial context that aligns with the modern pathologist's workflow. We can broadly visualize features like mitotic index using a heat map overlaid on a section of tissue, which gives a really nice overview of a sample's features at just a glance. We can also use the data to identify important features. Through univariate and multivariate feature exploration, we can begin to see patterns emerging for which features are offering the most information from a prognostic standpoint. This information alone is quite useful for identifying which features pathologists should be assigning more weight to when considering patient outcomes. Our final use case, and our most ambitious, is using artificial intelligence and QNG features to predict the probability of different patient outcomes, like we've done here with recurrence. Compared to statistical models, which are generally quite trivial to run, with very little refinement, QNG features and a random survival forest, which is a machine learning model, can perform similarly or better. In summary, grading as a tool for cancer diagnosis has been around for over a century. Our work aims to complement it with modern methods. The primary benefit of a quantitative nuclear grading is the opportunity for standardization, effectively quantifying a previously purely qualitative process. By adding a quantitative aspect, we hope that objective QNG-based metrics can be integrated into pathology workflows to guide treatment protocols. Additional benefits include the automation of a previously exclusively manual task, which means pathologists can spend less time reviewing slides and focus their effort on patient care and guiding treatment. Quicker turnaround on pathology review is also good for patients who can get diagnosed and treated faster, which is the best course for avoiding later metastases and recurrence. In the long term, we hope that this approach can serve as a foundation for data-driven pathology, where quantitative aspects enhance diagnostic precision and improve patient outcomes. Thank you.
So hello, everyone. I would like to first thank the organizers of OICR Mondays for inviting me to share some of our findings in bladder cancer. And while I'm not presenting the findings from our OICR funding, which is another thank you to OICR for funding us, I'm going to present some of our findings over the past 5 to 10 years along the axis of immune exhaustion and aging in bladder cancer. And I'm delighted to join Dr. Berman and his team and Dr. Michael Ong in this session on advances in bladder cancer. So in this talk, I will be discussing about some of our findings based on patient specimens and aging murine models of non-muscle invasive bladder cancer. And so far, our findings suggest that systemic and local immune exhaustion occur at multiple stages of bladder cancer journey. This is just a hypothetical figure that allows us to conceptualize multiple aspects of the patient's journey to understand why some patients experience poor outcomes following the gold standard treatment, such as BCG immunotherapy. So majority, as Dr. Berman already mentioned, majority of patients diagnosed with bladder cancer are within the age group of the age group between 55 and 85, and it peaks in the 7th, and the disease peaks in the 7th and 8th decades of life. This is very recent data from the United States, but the numbers are very similar in the Canadian landscape as well. And when we look at the global estimates from the Global Cancer Observatory at the International Agency for Research on Cancer, parallel to the rise in aging population, incidence of bladder cancer is also predicted to increase significantly over the next 2 decades. It has been really well explained, but let me re-emphasize one more time. Bladder cancer is categorized as muscle invasive and non-muscle invasive types. You just heard about a really good talk about the non-muscle invasive stages. And as discussed, the difference between the two types lies in the depth of tumor invasion into the muscle wall, as you can see here. So almost 75% of patients with bladder cancer present with early stage or non-muscle invasive bladder cancer, and approximately 25% present with more advanced muscle invasive bladder cancer, or MIBC, which, as David mentioned, can also result from a failure of response to treatment of NMIBC. And the graph on the right is a really good depiction. It's from data based on an Ontario cohort of 3,324 patients from Ontario with a median age of 71 years. And what you can appreciate here is higher progression rate was observed in patients with a higher stage and concomitant multifocal carcinoma in situ. These profiles of clinical outcomes have not significantly changed in the last few decades. Again, something that David mentioned, we are really proud to have Dr. Morales here at Queen's, who actually brought Bacillus calmette-guerin BCG immunotherapy into the world of bladder cancer, and it has been adopted globally. This is a picture from the celebration we had for 50 years of BCG. And this paper that he published in 1976 happens to be the most cited paper in the urological literature. So how does BCG work in a patient with NMIBC? David mentioned this remains to be the poster child of one of the most successful immunotherapies and still is the backbone of several newer treatments for NMIBC as well. So while we do not have a full understanding of how BCG mediates its anti-tumor effects, based on the mucosal vaccine literature, we can hypothesize that BCG leads to an activation. It's given intravesically, repeatedly into the bladder lumen at a certain regimen, and it leads to a cascade of integrated organ immunity by a process that involves early events of antigen presentation and processing, cytokine release, and bringing more immune cells into the microenvironment of the bladder so that residual cancer cells can be mopped up and the immune response can be boosted or stimulated against any cancer that may be recurring. So who gets BCG and why some patients do not benefit from BCG immunotherapy? It's a question that has remained for over 4 decades since BCG came into existence for bladder cancer patients. Patients who are at an increased risk of recurrence or progression, they undergo treatment with this repeated instillation of BCG in their bladders. And as I mentioned, what this approach does, it helps boost the anti-tumor immune response. But several patients do not obviously respond to the treatment, and that's why we have several new treatments that are in the non-responsive space. What I want to emphasize here is all these different stages that reflect different densities or distribution patterns of immune cells, and they all get pretty much the similar course of BCG. So I think there is something here that we need to, which is impractical to basically change the standard of care and the number of treatments and the schedule of treatment, but there's a lot we can learn from these environments and integrate host factors such as host age and sex into the treatment regimen by learning from what the pre-existing bladder tumor immune microenvironment is like. So for those who do not respond to BCG, again, this is very quickly, I'll go over it because David already mentioned all the new treatments that are on the horizon. I just wanted to emphasize the costs that are associated with all these newer treatments. And you can see some of these newer treatments such as the IL-15 superagonist or Adstiladrin, these or immune checkpoint inhibitors, they are working obviously, but they come at a higher costs. And this is based on a recent paper that was published in European Urology, a cost analysis done in patients from the United States, but the numbers are pretty much similar. As David mentioned, it's one of the most expensive cancers to treat. And it's very management intensive because of repeated cystoscopies that the patient has to undergo throughout. So we got the first hint of for pre-treatment immune exhaustion in the non-muscle invasive bladder tumor immune microenvironment from our study that was conducted in 2020, where we took a targeted approach of looking at 60 immune regulatory genes. And what we found was there was increased expression of immune exhaustion related genes in the pre-treatment microenvironment of tumors with a higher grade. And patients who experienced poor outcomes. And that was irrespective of treatment types. And then we did a multiplex immunofluorescence to look at the distribution patterns of immune cells that might be expressing these immune exhaustion-related genes, proteins. And in a cohort that was assembled by Dr. Berman's group, it was a total of 332 tumors on a tissue microarray. And what we found was an increased infiltration of immune cells and suppressed populations of immune cells within these tumors from patients who did not do well, irrespective of the treatment type. And around 173 of these patients underwent adequate BCG therapy. So other researchers have also found similar things in the context of response to BCG and the immune fitness and older age associated immune exhaustion. That is the major factor leading to poor response following treatment with BCG immunotherapy. So on the left, you're seeing a forest plot where this group from Denmark showed an increased T cell exhaustion score in patients who had a poor outcome or recurred early following BCG treatment, and these patients were over 70, majority of these Another study published in 2023 showed similar findings where there was an increased BRS3 was the group that had an increased expression of immune exhaustion related genes. And in this, most of the patients in this group, majority of the patients were older. So immune exhaustion in the pre-BCG tumor microenvironment of patients at a high risk of recurrence is either depicted as scattered populations of immune cells that are expressing proteins that reflect of an exhaustion state, such as our most favorite PD-1, PD-L1, but there are several others that we have identified and which are basically reflecting a chronically evolved tumor microenvironment. And it is known that bladder cancer development at this stage may take approximately 10 years. This is just based on a mathematical calculation, a paper that was published sometime in 2023 or 24, I think. So these features are reflected, the exhaustion features can be reflected as tertiary lymphoid structures, which are basically aggregates of immune cells. They can also be lymphomyeloid aggregates, or they can be fully formed germinal center-like reactions, which you may have observed in secondary lymph nodes so these are called ectopic lymphoid structures that are usually seen in mucosal surfaces. And these, as you can see here, I haven't identified the proteins here on this multiplex immunofluorescence image, but the blue here on top is the cancer. And this aggregate is basically a tertiary lymphoid structure, which is very close to the epithelium, tumor epithelium. And this structure mostly is expressing proteins that reflect an exhaustion state of those cells, which kind of reflects a long-fought battle between cancer and the immune cells, where obviously the immune system failed and the cancer progressed. So it's only 30 to 40% patients who express this kind of landscape in their tumor microenvironment. And this is best identified by looking at whole sections of these tumors. So while we found these TLSs to be associated present in both patients who responded and did not respond to BCG therapy, what we found was very interesting in terms of their expression patterns and densities in the tumor microenvironment. We used the nanostring GeoMX digital spatial profiling 44 immune-related proteins, and what we found was these were higher or increased in expression in tumors from patients who did not respond to BCG. So basically, TLSs, chronic TLSs, are present in both responders and non-responders, but their density, proximity to the cancer tumor epithelium reflects their exhaustive state, and that can be used to inform the disease progression or potentially a response to BCG. We also used a signature, which we call TLS imprint gene signature, which has been previously reported, and we added a few more genes to it. And if you just follow the blue bars, what you will see is these are the patients who did not respond to BCG and had an early recurrence or progression. And this was in silico analysis done from a cohort of 283 pre-BCG tumors, and the cohort was from Netherlands. And in the same cohort, if you remember, I showed this forest plot earlier as well. These BRS3 group is the one that does not respond, experiences early progression, and is enriched for older patients here. Just to summarize, TLS formation or lymphoid aggregate formation is a common feature of chronic inflammation on the mucosal surfaces. You may have heard about BALT, SALT, gut-associated lymphoid tissues. And within the bladder microenvironment, this may result from chronologic aging. So this is a mouse bladder. As you can see, there is no inflammation here, and there is this big lymphoid aggregate in the lamina propria. And this is a female mouse here. And this can also result from other chronic inflammatory conditions of the bladder, such as recurrent urinary tract infection, interstitial cystitis, smoking, obviously, autoimmune conditions. And in fact, our OICR project is basically looking at these chronic inflammatory conditions that may lead to such a landscape in the bladder tumor microenvironment, and how we can use these to inform treatment with BCG. When you stain with multiplex immunofluorescence, you can see classical structures of follicular dendritic cells, which are basically these yellow structures, and T cells in pink and B cells in blue. So it's basically what you see in a germinal center action, except these are not encapsulated. So the next question was, how do we model these in animals? And if you have looked at the literature, many would say that TLSs cannot be formed in mouse models, and that's mainly because most studies have been using younger animals, and in order to appropriately model, we really need to follow the age groups that reflect human age groups in our mouse models. And we really have to consider both male and female mice, because both of them have differences in their expression of immune-related genes, because of majority of immune response genes located on the X chromosome, for which females have, some of those have a double dose. So we have more immune response. And similar to humans, localized and systemic alterations occur during chronologic aging in mice. And given their short lifespan, it is very easy to mimic age groups where immune function decline initiates. For example, we do our studies mostly in the middle age, because that's when we think the cancer initiates, and we start carcinogen exposure at that state. So what you're seeing here is basically your male and female bladders of different age groups. These are healthy. So you can clearly see how the bladder microenvironment changes with aging, and how the adaptive immune response associated genes are enriched. So this is data based on bulk RNA sequencing. And again, as I mentioned, there is TLS formation that occurs because of increased TNF alpha in the bladder microenvironment and in a carcinogen exposed microenvironment as well. So it's a feature of chronic inflammation. And this is again the same, and you're seeing that we have characterized using multiplex immunofluorescence, where you see a lot of immune exhaustion reflected by increased PD-L1 expression in these TLSs because of chronic inflammation. Could be carcinogen, could be aging, could be repeated BCG exposure. So basically, female mice are reflecting a non-responsive scenario, which makes it really cool to explore and study sex differences. Although cancer is more prevalent in males, I think we can learn a lot, but TLSs are common in both females and males. So we can learn a lot in terms of modeling using these. So the question now arises as to why, despite all the high numbers of immune cells, these patients do not respond well to treatments. And as I said, it's partially due to immune exhaustion. And that exhaustion is mediated by pretty much all the cell type that undergo immunologic aging, B cells being one of those. And because it's mucosal immune response, B cells are the stars at mucosal immune responses because of their critical role in TLS formation. So what you're seeing here basically is the pathway that leads to exhausted B cells that are also called as atypical or age-associated B cells that expand under chronic inflammatory conditions or autoimmunity. And what they do is they suppress behavior of macrophages and cytotoxic T cells. So we thought that this could be one of the reasons that the disease is progressing despite the presence of that many immune cells. So we used the BBN carcinogen-induced mouse model, and what we did was we depleted these exhausted populations of B cells during BCG treatment. And here you can see in a mouse bladder, BCG is stained using Ziehl-Neelsen stain here. And what you're seeing is the whole the schematic that shows the entire treatment pipeline that we developed. And again, this is not practical to do in humans, but in mouse models, it just allows us to understand the mechanisms underlying progression of the disease. This is a progression model, basically. So we used both young and old models, and I'm showing young and old animals, and what I'm showing both males and females. And what I'm showing here is results from the older, because that make more sense in the context of older age and poor response to BCG. What we found was just without BCG, depletion of B cells reduced TLS formation and recovery of urothelium in female mice compared to, and this was more pronounced in female mice compared to male mice, as you're seeing here. And that's because, first of all, B cells are lesser in males compared to females. So there's something else going on in male mice, which we are just looking at. And probably that's something for another talk in a couple of years. So this recent study, I just want to emphasize here that patients with cancer exhibit an inflated immunological aging, and this has become an active and intense area of investigations because now we really appreciate that with aging, our immune cells, like any other cells, undergo several functional decline processes, and how we can use these signatures systemically or locally to understand disease behavior. I just want to draw your attention towards this particular graph where you're seeing an increase in memory population of B cells in cancer patients. You're seeing in females and males, that's the difference here. And you're seeing a decline in the naive cell populations as we age and within these age groups here. This is data that showed that depletion of B cells led to recovery of urothelium in more pronounced in female mice compared to male mice after repeated BCG. And what was very interesting was depletion of these exhausted populations of B cells. It also led to an increase in circulating plasma interferon levels of interferon gamma and IL-2 reflective of, and there was an increase in both Th1 and Th2 cytokines. And when we look at the bladders of these B cell depleted mice, we saw that there was a decrease in PD-L1 expression compared to the isotype group. Some of the recent successes that David has already alluded to, these are in the BCG naive high-risk space. There's a whole bunch of plethora of newer trials that are that are happening in this space, so it's really exciting. But this is just, I wanted to highlight some newer trial outcomes. The CREST trial that David just mentioned, which is basically subcutaneous PD-1 and intravesical BCG. I'm sure it's a very expensive trial. And another trial, and another one that is progressing, that is the use of gemcitabine docetaxel, which is very cost effective. And it seems to be working really well in the BCG naive high risk scenario. So these are two recent successes in older individuals, and one is quite cost effective, one is expensive, but both have led to some promise in increasing recurrence-free survival rates. But the durability is what is the main question. So what we are saying is, do we really need to exhaust that immune system that is already so exhausted? Well, when I talk to Dr. Siemens or urologists, they say you really can't change the standard of care of BCG therapy. You really have to give repeated dosing because that's the established protocol. But now, because of advances in technologies and all, we really know, we understand that immune exhaustion is so different across different stages and grades of bladder cancer, and maybe we should consider that and maybe develop something that leads to a lesser exhaustion of the local immune microenvironment in immunocompromised individuals, which probably our OICR study will reveal. This is landscape of trials and novel treatments for NMIBC. There's a lot going on in this space, both in the naive and unresponsive space. So in the next few years, we're really looking forward to seeing some successes with different treatments that David already mentioned. And in summary, I just want to mention that we really need to understand the disease from both the local immune microenvironment as well as the systemic behavior, because local administration of BCG leads to systemic immune activation, and those cells are brought to the bladder microenvironment. But these are older individuals with lots of comorbidities. Many of them have a lot of comorbidities, chronic inflammation. So we really need to consider those when we are looking at biomarkers for stratifying patients or developing personalized treatments.
Well, thanks for those two wonderful talks. After listening to Madhuri's, I think I'm the most expensive person in the room because I'm delivering some of these new therapeutics as a medical oncologist in Ottawa for bladder cancer. It's my pleasure to give you data that we presented at AACR this year. Is called the RADIANT study, a window of opportunity trial exploring preoperative immunomodulatory radiotherapy together with Durvalumab immunotherapy prior to radical cystectomy in patients with cisplatin-ineligible muscle-invasive bladder cancer. I know that's a mouthful. Also, I'd like to thank specifically our collaborators from OICR, Melanie Spears, who's been such a great collaborator with this project, I know on the line there's Megan Hopkins, Oliver Dessau, I saw. So thank you everybody at OICR for helping with this project. So I'm just gonna, there's my disclosures. So as has been said already, muscle-invasive bladder cancer is a very aggressive disease. And so when I see somebody in the clinic with this disease state, 50% of patients have metastases within 2 years, and 50% survive 5 years. And that's with, our traditional standard treatments. So that includes the local treatment, which can be radical cystectomy with pelvic lymph node dissection. That's our surgical standard. But in patients who don't end up getting surgery, bladder-sparing chemoradiation is an alternative. And then that's with traditional systemic therapy, neoadjuvant cisplatin-based chemotherapy, which only improves 5-year survival by 5%, and only 50% of patients are eligible for that treatment. And importantly, for looking at this RADIANT study, a benchmark pathological complete response with cisplatin therapy is about 30%. So we know for many years we've had to improve upon the standard of care beyond this. And of course, immune checkpoint inhibitors have been one of those tools that has improved care. So, for example, in cisplatin eligible patients for preoperative chemotherapy, adding anti-PD-L1 therapy with Durvalumab pushes the pathological complete response from 28 to 37% and improves overall survival. And we know that adjuvant anti-PD-1 drugs improve disease-free survival and are approved for the disease. And there were some interesting studies before on cisplatin ineligible patients where just the single monotherapy use of pembrolizumab or atezolizumab was able to have a pathological complete response of 31% or 37%, and doublet immunotherapy seemed to push it up a little bit more. So I think over the years, now I haven't presented the very exciting data of enfortumab, our antibody drug conjugate with pembrolizumab here, but safe to say that neoadjuvant treatments can very much improve outcomes. So our idea with RADIANT was that can we utilize external beam radiotherapy, which has been used over many years to treat bladder cancer, to actually prime the immune system for a better response to immune checkpoint inhibitor. And in thinking about this concept, we knew that dosing actually does matter in terms of how much dose you give. And at lower hypofractionated doses of radiotherapy, what happens is that you get this release of short segments of cytosolic DNA. And this is actually quite pro-inflammatory. It actually favors activation of the C-gas sting pathway, leading to ultimately interferon type 1 responses, CD8 positive T cell infiltrations into the cancer. And this may very much synergize with anti-PD-1 treatment. However, on the other side, if you give too much radiation dose, and in this preclinical study, 20 gray was given, you actually upregulate exonucleases like Trex1 that actually cleave up all that, inflammatory floating DNA. And you don't get that same kind of synergy. And they've done sort of on the right panel here, all different types of doses. And it seemed like a sweet spot would be around 8 to 10 gray per fraction. So on that basis, we designed a window of opportunity study. And David promised you that I would explain what that is. So, once in Canada, at least, once you decide that you're going to have surgery, there's a delay. You don't get surgery the next week. Surgery is probably coming 2 months later, even when it's something as serious as this. So in that window between the time that you decide you're going to do surgery and when you meet the patient, you have this gap where you can deliver some systemic treatment that could make a difference, or it could just be an opportunity to study whether it has any biological effect. So in this window, we recruited patients in this clinical study with clinical T2 to T4A node negative. So that's muscle invasive, and it could invade into a local structure, but not the pelvic sidewall. No lymph nodes that are clinically positive, no metastases, okay, and then at least a predominant histopathology of 50% high-grade urothelial carcinoma. Patients had to be fit, ECOG performance status of 0 to 1, and they also had to be ineligible for cisplatin chemotherapy or declined cisplatin chemotherapy. Nearly everybody in our cohort was ineligible. And then they completed a transurethral resection of the bladder tumor and were fit and planned for surgery. So in this study, the intervention then was one fraction of 8-gray radiotherapy to the whole pelvis, followed by 3 treatments with immune checkpoint inhibitors. So 3 in the blue, Durvalumab at 1,500 milligrams every 3 weeks. So they got 3 treatments, and then patients would go on to have their surgery. We collected all kinds of tissue and bloods for the correlatives. So we have baseline bloods, we have baseline urines, we have on-treatment bloods and urines, and then we have both the transurethral resection of the bladder tumor as the starting tissue, and then the radical cystectomy tissue afterwards. So our primary objective in this study was to look at pathological complete response. And I gave you some background data about what kinds of numbers we would expect. And our secondary objectives was to make sure that this was safe and feasible, meaning there were no signals that immune checkpoint inhibitors plus radiation would cause any safety issues or surgical complications. We looked at pathological downstaging rate, the recurrence-free survival, and overall survival at 1 and 2 years. And we looked at radiobiology and immune correlates. So our analytical plan for these tissue samples and blood samples included protein, DNA, RNA, and blood profiling by all the powers that OICR has. So digital spatial profiling, Olink, Oncomine, comprehensive assay plus, Ampli-seq, transcriptome, gene expression panels, and Oncomine TCR beta LR assays. So I won't go into details, and probably I'm not the best person to explain all that to you. So, from our clinical standpoint, our primary study hypothesis was that in cisplatin ineligible MIBC, if we gave preoperative 8-gray radiation plus PD-L1, this would be of interest to study further in clinical trials if the pathological complete response exceeds 40%, and there's the statistics. So at least 5 patients having complete response in this study. So here's the patient demographics. We accrued at 4 centers from both Ontario and Alberta. This was a small study, 14 patients. Predominantly male, sex as expected, 100% Caucasian, age was 73, everybody was fit, and cisplatin ineligible. 64% had muscle-invasive T2 disease, and 36% had T3 to T4 disease, all node negative, 36% multifocal. And on the topic of BCG, 29% had prior BCG therapy. And 79% had what we thought was an optimal complete transurethral resection prior to the study. In terms of treatment completion, side effects, what we really found is that radiation and Durvalumab was not the main reason that there were adverse events in this cohort. As you can see in the arrows, radical cystectomy and pelvic lymph node dissection is a huge surgery, leading to a lot of complications. And in terms of related adverse events, 46% of patients had surgical related issues, and the majority of grade 3 or 4 or severe side effects was from surgery. But there was no treatment-related delay from our intervention. Surgical complication rates were good, and the surgeons thought that the difficulty scale was easy to moderate in the majority of patients. This is the primary endpoint of our study. We found that 50% of patients had complete pathological response in this small cohort. That's 7 out of 14 patients. And 57% of patients actually had partial response or better. And we had 43% non-responders. And actually, just to highlight how binary this outcome is, some of the non-responders were actually quite poor, meaning 2/3 of them had node-positive disease even after the intervention. So I think that they clearly had no response at all if that was the case. We did look at characteristics that were associated with a pathological response. It actually had not as much to do with the entry stage, T stage, or prior intravesicular treatment. And I think there wasn't a signal here that complete transurethral resection was the signal. Multifocality seemed to associate with more pathological response, and lack of desmoplasia, which actually is probably that was coded by surgeons. It was actually more of an indicator of progressive disease in the non-responders. And here's an example of a patient that had this is a post-TURBT recurrence. This was the patient's baseline imaging. This was the intervention, radiation, Durvalumab. You can see here that the pre-op CT looks like there's substantial radiographic response. And then here's the final pathology, which was reported as negative for urothelial carcinoma. There's an ulcerated urothelial mucosa. There's necrotizing granulomatous inflammation and transmural fibrosis. In terms of some of our correlatives, we found that patients that were responders were enriched for DNA damage repair alterations, as you can see in this panel, that their tumor mutational burden was higher, and there was more of a preponderance of luminal subtype by TCGA rather than basal. And looking at some of the O-link changes, there was a signal that, this wasn't a randomized study, so we're trying to look at the gap between, in the red here is what we have at baseline, blue is immediately after radiation, and green is after all the immunotherapy at the time of cystectomy. So there's a signal that some of the angiogenesis and wound signal, for if you will, post radiotherapy is increased immediately after radiation, and in terms of the green, there's not surprisingly upregulation of proteins related to immune checkpoints, pro-inflammatory signaling, post-immunotherapy with Durvalumab. This cystectomy tissue was imaged by digital spatial profiling, and essentially we found that responders had enrichment for T cell activation and immune checkpoint inhibitors. And so these are the plots associated with the DSP. So, things like VISTA, CTLA4, PD-L1 are upregulated, and then CD27, ICOS, 41BB, all targets we know well, right? Non-responders seem to have some enrichment in BCL, XL. These were the Kaplan-Meier's for overall survival and progression-free survival based on responder or non-responder. And so just to highlight, 18-month progression-free survival was 83.3% responders and 33.3% in non-responders. And same thing for overall survival, same numbers essentially. So in conclusion, we found that a single fraction of A-grade radiotherapy and 3 cycles of immune checkpoint inhibitor with Durvalumab had a promising pathological complete response of 50% with a partial pathological response of 57%. This was safe and feasible. There was no surgical delay. There's no increase in operative complexity. Responders had better long-term clinical outcome, and responders were enriched for DNA damage alterations, high tumor mutational burden, a luminal subtype. And radiotherapy led to an increase in angiogenic signaling And the combination led to increased pro-inflammatory markers, immune checkpoints, and T cell infiltration. And, why is this topic of interest? I think there's many reasons to think about how we can better integrate radiotherapy into localized muscle-invasive bladder cancer. And right now, as you know, there are many new systemic therapies that are progressively pushing up the pathological complete response higher and higher. And drugs like enfortumab together with pembrolizumab in cisplatin ineligible patients has been reported with very good outcomes, and we're awaiting the cisplatin ineligible trials. And as we keep pushing that up, I think the question comes that should we be doing surgery at all in these patients, right? When we're in this study reporting PCR over 50% or 50%, did those patients need to have surgery? Or, and I think that that's a very important question that I think the whole field is trying to address. And so when we choose in some of these patients not to do surgery, radiotherapy is an alternative that can be integrated. So I'd like to thank you for your attention, and I know we have time for some questions.